may still remain in the liver cells, and in the setting of immunosuppression, they can reactivate. And I do talk about this a little bit later. So I think we might spend some time going through this slide. So in terms of, I guess, the main things to order when you're testing for hepatitis B, obviously you would test for surface antigen, as mentioned before. It tells you whether it's a chronic or an acute infection. And the second and third thing to test for is core antibody and surface antibody. So a patient who has acute hepatitis B would be positive for surface. They will be positive for the core. They don't have enough time yet to develop the surface antibody. And if you test for IgM and the laboratory tells you that it's positive, then it's most likely an acute hepatitis B infection. I think the IgM becomes positive after maybe 4 to 6 weeks. There are a few questions. Nope, nothing in the chat. Good. And then next, in terms of chronic hepatitis B, as mentioned before, surface positive, core positive, because core is only found in the virus. And again, surface is negative because they've not developed any antibodies to the surface antigen. Next, if you do a hepatitis B blood test and the surface negative, great, they don't have chronic or acute Hep B, but they're core positive and surface positive, then they have previously had an infection and have cleared it, or their own immune system has cleared the hepatitis. And finally, if all you have is a positive surface antibody, then that means they are immune through vaccination, because again, you only get core antibodies from a previous viral infection. And then you have these other, you have this other type called where you just have you just have a positive core antibody, but the negative is surface. And there's a couple of possibilities in this situation. So it could be just a resolving acute hepatitis B infection. It could also be a false positive, or it could be the occult hepatitis B, as we mentioned before, where the DNA is detectable. And finally, a patient who's negative for everything should probably have a vaccination booster, as they're susceptible to having hepatitis B from bloodborne exposure. So the main thing to know for acute hepatitis B is that in adults, it's generally self-limiting, especially in patients who have a competent immune system. Whereas in infants and babies, the progression from acute to chronic is much more common. In fact, up to 85 or 90% of babies who get it will develop chronic hepatitis B. And the reason for this is based on the strength of your immune system. There is a 1% chance in patients who develop acute hepatitis B to develop what's called a fulminant hepatitis B, so the most severe type of hepatitis B, where you develop acute liver failure of coagulopathy, so your international normalized ratio will be abnormal. And also you will be encephalopathic, and there's usually a severe hepatitis with this. And without a liver transplantation, only 25% will survive this. All of these patients will invariably end up in the intensive care unit. And the risk factors for developing acute liver failure is patients who acquire it when they're older, patients who have, and patients who have co-infections of Hep C or Hep D. Next, in terms of chronic hepatitis B, it's extremely common, affects about 250 million people worldwide. And I was just told now that in Myanmar, I think up to 50% of people are known to live with hepatitis B, so extremely uncommon and probably underdiagnosed. In Australia, about 200,000 people live with chronic hepatitis B. Now, globally, the most common form of transmission is from mother to child during birth, or vertical transmission. Whereas in Australia, the most common route is from newly acquired infections from injecting drug use or sexual contact. The risk of chronic infection, again, as mentioned before, is highest in early life. So the guideline that I refer to do suggest that these groups on the left should also be screened, as in they should have testing for all three: surface antigen, core antibody, and surface antibody. And that population includes anyone who's pregnant, given the risk of giving into the baby, anyone who's getting immunosuppression, and I will talk about that. Anyone who's a healthcare worker, nurses, doctors, anyone who, I guess, take bloods regularly, people with other chronic liver diseases such as metabolic fatty liver disease, people who are on renal dialysis, obviously, because they need regular blood tests and also regular cannulation from dialysis. People with HIV should also be tested for co-infections. People that live in the same household as anyone with chronic hepatitis, and also children who are born to parents with chronic hepatitis. So I won't go into too much detail as the idea, and well, let me start. So this is the life cycle of the hepatitis B virus. The most important, or the two, I guess, most important things to know from this slide is, number one, the virus enters via the NTCP receptor, and I do have on another slide what that stands for. But basically, using this receptor, the virus enters the hepatocyte and then essentially incorporates itself into the host DNA, which is why at the moment we cannot cure hepatitis B, because we cannot undo this process of the DNA inserting itself into the genome, and then using the cell's own mechanism of making proteins and replicating DNA, it's able to make more cells. It's able to make more viruses, and one of the enzymes just here, the hepatitis B polymerase, which comes with the virus here, is the target that is treated or targeted when we give entecavir or tenofovir to treat hepatitis. Now, I might spend a little bit of time on this slide. This essentially outlines the lifespan or the life cycle of the 4 phases that we probably have learnt of about hepatitis B, what's previously called. So up here, they've got new and old. The old term is immune tolerant, immune clearance, immune control, and immune escape. And the new terms that in Australia they're looking to introduce is whether it's depending on the E antigen, which I've not talked about yet, whether the patient is E antigen positive or E antigen negative, and whether they have a chronic infection where there is no abnormalities in the ALT or the liver enzymes, or whether there's chronic hepatitis, where in these 2 phases, 2 and 4, there is hepatitis where there is abnormal ALT. And the most important thing to know of these 2 points is that these are the 2 phases where we give treatment or start treatment with entecavir or tenofovir. The red line up here shows the DNA viral load throughout the 4 phases. So at the very start, when they've just acquired it, generally in the first 20 years of your life, the DNA viral load is extremely high. And then as you age, it slowly reduces to the point where it becomes nearly at a very low level once you're in the immune control phase. Now, as mentioned previously, these are the 4 phases. And one of the things to note is that patients do not necessarily go from 1 to 2 to 3 to 4 in that order. They can certainly go back and forth, and they can also miss a phase altogether. So they can go from 1 to 3 or 1 to 4. Now, in terms of what is an abnormal ALT, the guideline is recommending that the new limit of normal should actually be 19, and that a female with a number of above 19, so 20 or above, or for males 30 or above, would be abnormal. And the basis for this is based on the study that was done in Korea, where they looked at ALT levels and the risk of mortality from liver disease. And they found these numbers as an adequate cutoff to define normal. Our laboratory at our hospital in Brisbane, I think, uses a number around 30 something for females and maybe even 40 something for males. So in more detail, in phase 1, the immune tolerant phase, it's E antigen positive. So E antigen is a reflection of viral replication. It's also a reflection of your ability to or your risk of transmitting hepatitis B virus to other people. It's usually seen in vertical transmission from the mother. It lasts between the first 10 to the first 40 years. Usually extremely high hepatitis B DNA, between 100,000 to millions. Usually no evidence of inflammation, so a normal ALT. And if you do a liver biopsy at this point, there's little or no fibrosis and very low inflammation. And usually we don't treat patients who are in this phase. Then in phase 2, this happens a little bit later in life. There is inflammation in the liver, and there's a risk of also developing fibrosis and cirrhosis. The E antigen is still positive, and the DNA level is still quite high. At this point, the ALT usually is abnormal, and if you do a liver biopsy, there is evidence of inflammation, and the inflammation is because of your own host immune cells responding to the virus and causing the damage. At the moment, we're not too sure about the mechanism for going from phase 1 to phase 2, but the reason is they think that is because the host immune response is not very effective in the first phase, whereas now it's responding to the presence of hepatitis B. We might move on. So the main thing to take away from the slide, and I will come back again, is that usually at this point, if there is ongoing hepatitis B replication, so elevated DNA and elevated ALT or abnormal ALT, then we start treatment with entecavir or tenofovir. In phase 3, E antigen seroconversion is the main thing. So the patient is now E antigen negative. There is a reduction in hepatitis B replication and the hepatitis resolves. So the DNA level is much lower, less than 2,000 copies, and a normal ALT. And both the blood tests and histology or liver biopsy look much better. And phase 4 is once again where you have evidence of hepatitis, where the main thing is the DNA is more than 2,000 and the ALT is once again abnormal. So on the basis of this, this usually happens in patients who are older, and they're usually older patients. And once again, the mechanism between going into this phase is not 100% clear. Now, in 1/3 of patients, they go from, they transition to this phase from the previous phase 3. And the most important thing to know about this phase, which you're probably now aware of, is that abnormal ALT means inflammation and fibrosis, and we do treat with entecavir or tenofovir. In addition to this, there's also an elevated risk of developing cirrhosis. There's a high risk of developing hepatocellular carcinoma, which I've abbreviated as HCC, due to the oncogenic effect of hepatitis B. I want to talk about the occult hepatitis B too much, other than the fact that this was what I mentioned on the second slide, where there's no surface antigen, there is a very low level of DNA, and it's very rare even in Australia. And they think that the reason for this is because of a mutation, and that's why the surface antigen and this hepatitis B virus is not registered, so it's a false negative. Now, the main thing to talk about for this slide is in patients who are in phase 6, or patients who have had hepatitis B and have cleared it. In these patients who have either advanced fibrosis, so sort of F3, F4 fibrosis on the FibroScan, or who have evidence of cirrhosis or chronic liver disease, then even in these patients who have cleared the hepatitis B, the most important thing is to still continue 6-monthly liver cancer hepatocellular carcinoma surveillance. So if you've seen a patient and diagnosed a patient with hepatitis B for the first time, then in addition to the E antigen that we talked about before, an E antibody, and obviously the core antibody, surface antibody, then the next thing to do is to see whether the patient has cirrhosis or not, or whether they have advanced fibrosis. In addition to this, you should also test them for all of these other viruses to check whether they have a co-infection to HIV, HCV, or hepatitis D. In addition to this, also important to check whether they're immune to hepatitis A, and also important to note whether they have any other comorbidities such as ongoing alcohol excess, whether they're a smoker, whether they have obesity, whether they have diabetes, or whether they have any non-alcoholic or metabolic, or MAFLD is a new term, so what is called non-alcoholic fatty liver disease, that may also increase their risk of developing cirrhosis in the future. And finally, do they need to be screened or be on the surveillance program for HCCs, which includes whether there's a family history of HCCs. So in terms of test or assessing for whether a patient has advanced fibrosis or cirrhosis, one of the more reliable tools that's well validated is transient elastography, which is a procedure that in Australia, generally our clinical nurses perform, where basically the patient comes in having fasted, using a modified ultrasound probe that sends Doppler waves back and forth, and using this, it gives a reading of the stiffness of the liver, and the higher the stiffness, then the more likely the patient is to be cirrhotic, and there are a few things that can affect the stiffness reading, which I will talk about. In general, the main thing to know about this is it's very good at excluding cirrhosis. So if the stiffness is 3.9, if it's very low, then the patient is very unlikely to be cirrhotic. If the stiffness is very high, then the patient is very likely to be cirrhotic. But if the number falls between sort of 5 to 10 or 5 to 12, then it's a little bit tricky. It's sort of a gray area, and you need to do other tests. What's also readily available is the APRI score, which is validated in hepatitis B and hepatitis C, where all you need is the AST and the platelet count of the patient. And again, just like the elastography, it's very good when it's very low. So less than 0.5, the patient's very unlikely to have cirrhosis. If the APRI is greater than 2, the patient's very likely to have cirrhosis. But anywhere in between, it's harder to tell. And this is what I talked about. So there's a lot of information from this slide, but all I really want to talk about is for the APRI score that we just talked about. If you get a number greater than 2, then the specificity for cirrhosis is 87%. But the problem is it's not very sensitive, so you'll miss a large portion of patients who might be cirrhotic who don't meet the cutoff. Now, and the other limitations of transient elastography is that patients who are obese, so a body mass index of greater than 30, or patients who have ongoing inflammation or hepatitis, if you imagine, you get a elevated stiffness value, so you should repeat that when the inflammation has resolved. That's mainly it. Yes, it's best to exclude cirrhosis with a very high negative predicted value. Now, I guess the most important thing that I want to talk about in this talk tonight is about the treatment of chronic hepatitis B. There are 3 in Australia that are available. And from what I'm aware now, there are definitely 2 that are most familiar to clinicians in Myanmar, which would be entecavir and tenofovir. In Australia, generally, entecavir is very common, very readily available, and generally used first line. They all have very high antiviral efficacy. They're all very good at suppressing the DNA. They're all mostly pretty safe. Entecavir probably less side effects, and they're all very, very minimal side effects with the drugs. You can use them in nearly all patients with hepatitis B. In addition to this, they're also the only options for patients who have decompensated liver disease or who have extrahepatic manifestations, or in patients who have had a liver transplant. In addition, if a patient is going to have chemotherapy, or if they have immunosuppression, then they need prophylaxis to prevent reactivation, then again, these are the only 3 drugs that can be used. So in Australia, we have what's called the PBS, the Pharmaceutical Benefit Scheme, where essentially the government covers most of the costs for these drugs. And what's listed on on the PBS are entecavir, tenofovir, disoproxil, TDF, and peginterferon, which is very, very, very less commonly used. These are the doses, and I'll talk about them a bit more. The side effects are very rare, one being just lactic acidosis. The pregnancy categories for entecavir is category C, so in pregnancy we use B, and I will talk about this later. And for both entecavir and tenofovir, the main thing to tell your patients is that they will need to be on these medications for life, forever. Although there are certain situations where you can stop it with a risk that the virus can flare again. TDF has some more side effects, which include causing kidney impairment, kidney problems, nephropathy. It can also reduce the bone mineral density. So patients who are already at risk of low bone density, if they are on steroids, if they're postmenopausal females, then I would consider perhaps entecavir, or you would need to monitor the bone density very closely. In addition to this, we may have heard of Fanconi syndrome and lactic acidosis once again. So as mentioned before, randomized control trials that have compared entecavir, tenofovir, disoproxil, and tenofovir alafenamide, alafenamide, TAF, have shown no real difference in their ability to suppress DNA, convert the E antigen, or very low cause of causing a functional cure, losing the surface antigen. And what is the goal? What are we trying to achieve with giving patients the drugs? It's really to suppress the virus, which means improving the histology, reducing the inflammation. The cirrhosis or the fibrosis can improve also. And we want to reduce the risk of developing cirrhosis, the risk of developing decompensated chronic liver disease, reducing the risk of needing a liver transplant, and also developing hepatocellular carcinoma. So hopefully once you tell the patient that it really prolongs their life, they're less likely to die from cancer, they're less likely to die from chronic liver disease, then that should help you in the patient being able to take a medication for the rest of their life forever. The guideline that I am referring to shows certain situations where you should use one tenofovir as opposed to entecavir. So the first one mentioned here is a patient who have had previous nucleoside analogs. And that include medications such as Adefovir, which is a much older drug. Anyone who's had previous exposure to any hepatitis B or HIV treatment, they should have tenofovir. And the reason is because there is essentially no resistance to tenofovir. So it's very, very, very good. Anyone with bone disease, entecavir will be preferred. And risk of bone disease, as mentioned before, I have it down here. So chronic steroid use, chronic prednisolone use, or any medication that can affect bone density. So epilepsy, seizure drugs, I think, can do that too. Or a history of fractures, or if a patient has osteoporosis already. Anyone with renal disease, entecavir is a better drug. Pregnant patients, tenofovir, and cirrhosis or decompensated cirrhosis. And just to clarify for everyone, decompensated cirrhosis as in a patient with chronic liver disease who has a variceal bleed, variceal hemorrhage, hepatic encephalopathy, or ascites. What I have on the right side here, this is an Australian website, and it's quite helpful in that it tells you based on the creatinine clearance, which is worked out based on creatinine and I think weight and height. Based on the creatinine clearance, what to dose for the entecavir if you give entecavir. So above 50, you give normal dose, 0.5 milligram once a day. Below that, you can go to 0.5 every second day. Even lower than that, 0.5 every 3 days. At the very lowest, so a patient who's on dialysis, for example, you can still give it. You just have to give 1 tablet every week. So coming back to the 4 phases, in phase 1, so if we remember, E antigen positive, very high DNA, but normal ALT, the ALT is normal. We don't treat in this situation just because the risk of, essentially the risk of fibrosis and developing chronic liver disease is actually quite low, and there's a chance the patient could clear the infection. However, there are certain situations where you can consider, even if they have a normal ALT, consider putting them on entecavir or tenofovir, and the indication for that could be if they're at a high risk of developing liver cancer, so a first-degree family history of HCCs, if they're above the age of 35, so against a slightly higher risk of HCC, if they have another infection like hepatitis D or hepatitis C, if you are worried that they could transmit hepatitis B to other patients or other health workers, if they have extrahepatic manifestations, or if they have another liver disease at the moment, such as if they're obese and diabetic and have high cholesterol, or if they have alcohol liver disease. In phase 2, as we talked about, so still E antigen positive, but now they have hepatitis, so the ALT is now abnormal, and the DNA is above 20,000. So in Australia, this is a specific cutoff on the PBS to be able to prescribe the medication at a cost, at a lower cost. You start treatment in this phase. And then patients who are in phase 3, they're under, the immune system is controlling it, a very low DNA, the ALT is normal, no inflammation, no treatment. And in this case, you just continue to monitor these patients, probably with blood tests, I'd say maybe every 3 to 6 months, to see whether they move into phase 2 or phase 4, where you will treat. And finally, in phase 4, the immune system is responding to the hepatitis B. The DNA level is elevated, the ALT is elevated, and in this phase, we do treat. In addition to this, another strong recommendation is that any patient who have cirrhosis, chronic liver disease, and any hepatitis B DNA, and regardless of the ALT, whether it's normal or abnormal, they should definitely be treated with antiviral therapy. And the reason for that is once they have cirrhosis from hepatitis B, their risk of developing HCC is much higher. I won't talk about this too much, but there are very specific situations where patients who do not have cirrhosis, patients who have had 12 months of e antigen loss, and patients who are e antigen negative who have had no detectable DNA for at least 2 years, you can potentially stop tenofovir or entecavir. However, the main thing is there is a risk that they can develop a severe hepatitis reactivation once you stop it, with a very severe hepatitis, jaundice, decompensation, which is why you need to monitor them closely. So outside of meeting these criteria, I think the safer thing to do might be to just keep them on tenofovir and entecavir to prevent the other risks of having hepatitis B. Now, in terms of resistance, generally it's very uncommon, especially if you use entecavir and tenofovir, which we say both have a very high barrier, as in it's very unlikely for viruses to develop resistance to them. So if a patient who has had no DNA detected, who suddenly has a detectable viral load, the most possible explanation for this is just non-adherence or the patient not taking the medication appropriately. And usually, if you just speak to them, they'll tell you they've not been taking it. And once they take it, the DNA becomes suppressed again. However, if they are taking it appropriately and the viral load is going up, then in this case, you do need to think about viral resistance. In practice, again, tenofovir has the highest barrier to resistance. There's no known resistance. And at the moment, at least in Australia, routinely testing for resistance is not generally available. So what would be preferable in this setting is really changing to another drug. So this slide in Australia, because we mainly use entecavir and tenofovir, the only situation would be a patient who's on entecavir, you either switch or you add tenofovir. I'm not sure whether these drugs are commonly used in Myanmar, but if they are, then if a patient who's on lamivudine, talbivudine, or adefovir, then if you're worried that developing resistance, and that would be if the DNA increases by 10 times. So if it's 100 one time and 3 months later it's 1,000, then you worry that there is virus breaking through. Then the most preferred strategy is just switching to tenofovir, and there shouldn't be a problem. And from what I understand, tenofovir seems to be the more common drug, in which case this should not be an issue at all. I do want to spend some time on just the top of this slide about hepatocellular carcinoma surveillance. So anyone who has cirrhosis need 6 monthly liver ultrasounds and alpha-fetoprotein blood tests. People who do not have cirrhosis also need to be screened, so need to be surveyed for HCC. So Asian men who are above the age of 40 who have chronic hepatitis B who do not have cirrhosis, they should be screened. In addition, Asian women who are older than 50, once they turn 50, should be screened. If you're treating any patient who are from sub-Saharan Africa above the age of 20 should be screened for liver cancer. Patients who have a co-infection with hepatitis D, patient with a family history of HCC, and other risk groups. There are certain other racial groups that I won't talk about that should be screened. So in terms of specific populations and what to do with their chronic hepatitis B, so in pregnancy or women who are lactating, the hepatitis B itself actually doesn't have a very much of an impact on the outcome of the mother or the outcome of the baby. It can flare during pregnancy and usually is quite mild and it's self-limiting. The main goal, as mentioned before, is to prevent perinatal or vertical transmission. So when the DNA level at the time of birth is very high, and what I mean by that is more than 200,000 or in the millions, then the immunoprophylaxis, the immunoglobulins, and vaccination, if given at the time of birth, it's only 90% effective. And therefore, when the DNA viral load is more than 200,000, or oftentimes in the millions, towards the end of the second trimester, then during the third trimester, after 28 weeks, we would start tenofovir. As we remember before, tenofovir is the one that's safe in pregnancy and breastfeeding, very effective, very little resistance. In Australia, on the PBS specifically, if the mother is not already on tenofovir but needs to be on it during pregnancy, they can take it for the last 3 months of pregnancy, the third trimester, and for 3 months after birth. And then the other thing to mention is if a woman is on entecavir before pregnancy and she becomes pregnant, then you should switch to TDF or tenofovir. And usually we stop the medication about 6 to 12 weeks after delivery, and we still monitor them with regular blood tests. And if they, after pregnancy, the indication is, as mentioned before, phase 2 or phase 4, then we would start treatment again for that reason. In the setting of immunosuppression, reactivation is defined as a DNA that increases by 10 times from baseline, or a surface antigen that converts in a patient who previously, who had evidence of previous cleared infection. So they're positive for the core antibody, but negative for the surface antigen. If they reactivate, they can become surface antigen positive again. So I think the main thing from this slide that I want to talk about is patients who have evidence of previous hepatitis B, so surface antigen negative, core antibody positive, who are going to undergo high-risk chemotherapy, such as stem cell transplantation, or if they receive any B-cell depleting agent. So what I mean by this is any patient who needs rituximab or some newer agents with CD20 or CD38 B-cell effect, such as obinutuzumab, ocrelizumab, or fatumumab. So ocrelizumab is used in multiple sclerosis, and daratumumab and ibrutinib. Then any patient who's getting treated with these therapies, or if they have acute leukemia or high-grade lymphoma needing chemotherapy, you would start prophylaxis with entecavir and tenofovir to prevent reactivation of hepatitis B. And any patient who is surface antigen positive, but I guess doesn't meet the DNA criteria of 2,000 or 20,000 from the earliest slides, any sort of cancer chemotherapy at all, you would give entecavir or tenofovir as prophylaxis. In terms of other forms of immunosuppression in a patient who has hepatitis B, so the highest risk, again, are the B-cell depleting medications like rituximab, or high-dose prednisolone or prednisolone equivalent, more than 20 milligrams per day for longer than 4 weeks, very high risk of more than 10% risk of reactivating hepatitis B. In patients who are surface antigen positive, who are receiving either high risk or moderate risk, and moderate risk includes TNF alpha, so infliximab, adalimumab, or listed below here, etanercept, certolizumab, for mainly in Australia used in rheumatoid arthritis or psoriatic arthritis, or of course inflammatory bowel disease, Crohn's disease, ulcerative colitis. Patients who are surface antigen positive who are getting TNF should have entecavir or tenofovir. And patients who are surface antigen positive who are getting the low risk immunosuppression. So what is low risk? So thiopurines, azathioprine, methotrexate, or calcineurin antagonists, so cyclosporin or tacrolimus, or low dose steroids. You don't have to treat. You can just monitor on a 3-monthly basis. And you might want to know, you might be asking, what about patients who are surface antigen negative or a core antibody positive? So previously cleared hepatitis B. What do we do about these patients? We generally do not give prophylaxis because the risk of patients who are not getting B cell depleting agents, the risk of the hepatitis B reactivating is generally very low. Yes, so anyone who, if a patient is going to get rituximab, you continue in tenofovir or entecavir or nucleoside and analog treatment for at least 12 months after cessation of any non-B cell depleting immunosuppression, and for essentially 2 years after you finish rituximab. Patients, now the next thing is, if you diagnose a patient with hepatitis B and hepatitis C, what do you do? The risk of liver disease is much higher and much quicker when they have 2 infections. So the main concern in this situation is these patients who get direct acting antivirals for hepatitis C, like Epclusa or Mavorite, there's a risk of hepatitis B reactivating, which results in fulminant hepatitis, and the patient can actually die, which they have documented in patients who get Hep C treated. So what do you do? So in patients who are surface antigen negative and core antibody positive, so previous infection, the risk of the reactivation is extremely low, so you don't need to worry about it. However, if they're surface antigen positive and they're also getting treatment for hepatitis C, they are at risk of hepatitis B reactivation. And so in this case, people who are either cirrhotic or who meet criteria for hepatitis B treatment should also be treated for entecavir and tenofovir. Patients who are not cirrhotic and the DNA is below 2000, you can also consider hepatitis B to reduce the risk of hepatitis B treatment, to reduce the risk of reactivation. In patients who have hepatitis D and hepatitis B, previously we didn't have very good treatment, but there's something that's been approved in Europe that I'll talk about now that does seem to be quite effective for treating hepatitis D. And in terms of areas where it's quite common, seen in Africa, mainly Central and Northern Asia, less so in Southeast Asia, Pacific Islands, Middle East, Eastern Europe, and South America. Previously, all we had was PEG interferon, and it was only effective in 50% of the people. And tenofovir and entecavir are not effective against hepatitis D. However, there's a new drug called bulevirtide, which is a new drug that actually works for both hepatitis D and hepatitis B through the inhibition of the channel receptor. If you remember back to the picture I showed earlier in the talk of how the hepatitis B virus enters the cell, it blocks this and blocks the hepatitis D from entering the hepatocyte. And what they've also noted is that there's also a 10% chance of loss of hepatitis B surface antigen. As we know, hepatitis D requires hepatitis B, so you would always see them together. There's a loss of surface antigen, 10% of people who are treated with PEG interferons, and I guess that suggests cure from hepatitis D. I won't talk about this too much. This is the receptor that this medication acts on that we talked about before. They conducted the trial with a low dose, a high dose, no treatment, then the high dose. And what they found is that the hepatitis D RNA is log 2, so 100 times less compared to no treatment. When used in combination, there is a combined response where there's undetectable hepatitis D RNA, more than 100 times decrease in the RNA from baseline and a normal ALT, and both doses of the drug works. There's a very good evidence for virological response with this drug. and also the ALT going back to normal, which is also very impressive. There's very little serious side effects from this. There's no deaths from this drug. Now, in a patient who has concurrent hepatitis B and HIV, it is a little bit different in how you treat this situation. Again, hepatitis B DNA, the rate of E antigen remaining positive, the development of chronic hepatitis B and chronic liver disease related mortality and death are all actually higher in patients who have both HBV and HIV compared to just HBV. In addition, without treatment, developing fibrosis is more rapid and becoming cirrhotic is more common. And therefore, patients who, what they've noted is that the risk of liver disease is much lower in patients who are on long-term suppression with tenofovir-based antiretroviral therapy for their HIV. Treating both infections should be with HBV effective antiretroviral therapy, which really means tenofovir. And you would treat it regardless of the phase, whether it's phase 1, 2, 3, 4, you would treat it. In Australia, TAF, the alafenamide, is available for people with HIV. There's less kidney problems, there's less bone problems, and it's preferred compared to TDF. In addition, is also TAF or tenofovir is safe in the treatment of HIV in pregnancy, as we know. Entecavir, unfortunately, is not particularly good for HIV and can also lead to HIV resistance. And finally, what they are starting to notice in Australia in the last 20 years is that there's an increased risk of hepatocellular carcinoma in people with HIV and hepatitis B. And it is still quite a leading cause of liver-related death in people with HIV. And also people who have HIV who develop HCC also have a lower survival and higher mortality. And therefore, patients who have co-infection, even if they don't have cirrhosis, should have 6 monthly liver ultrasounds for HCC surveillance. Now, in a patient who has renal impairment, I think we've talked about before, usually if they are on tenofovir, then please monitor their serum creatinine, their eGFR, their phosphate level every 3 months in the first year and every 6 months in the years thereafter. If patients develop renal impairment or hypophosphatemia, then in that case, either you can switch to TAF if it's available, or entecavir. So I guess entecavir will probably be preferred. You can use these medications for patients who are on dialysis, and generally, if they're on dialysis with hepatitis B, they should both be screened. If they're not immune, they should have a vaccination booster. If they have surface antigen positivity, then they should be monitored. If they meet phase 2 and 4, they should be treated. And usually the treatment with these two drugs, which have less renal side effects, so entecavir or TAF should be used. And remembering to early in this talk that if an eGFR is less than 50, then you should dose reduce entecavir as suggested. Do not give adefovir or tenofovir as they're nephrotoxic, and definitely do not give in patients who are on dialysis who have residual renal function. So I guess that would be your patients who are on peritoneal dialysis who still have urine output. And PEG interferon is safe in those who are on dialysis, but it's poorly tolerated and the efficacy is uncertain. Now, in terms of patients who have had a renal transplant, if they're surface antigen positive recipients, then you should start tenofovir at the time of transplantation, and you continue it long-term even if there's a low DNA level. and as mentioned here, as it's a renal transplant, then entecavir is actually preferred. In patients who are recipients who are positive for just core antibody but negative for surface antigen, then it's not as clear in terms of whether they need prophylaxis. We at the moment just recommend monitoring for surface antigen emergence and then treating irrespective of the ALT. And as mentioned before, routine prophylaxis is not usually recommended. If the patient does, however, develop acute rejection, for example, to the renal transplant, and they need T-cell depleting therapy such as ASCAM or thymoglobulins, then in that case, we would give prophylaxis. In terms of liver transplantation, in Australia at least, they used to transplant up to 10% for hepatitis B. Prior to this, back in the 1980s, they did not transplant for hepatitis B related cirrhosis because there was a fear that the hepatitis B can recur. It's done much less commonly nowadays. Because hepatitis B immunoglobulins are available, the risk of reinfection after transplant fell to around 30%. And the patient does need to be DNA negative at the time of transplant, as the immunoglobulin is not effective in those with very high viral loads. Nowadays, now we have tenofovir and entecavir. We don't usually need to use as much immunoglobulins. They can be stopped much earlier, whereas previously they needed to go, I think, forever. And it's just a graph to show that patients who have had a liver transplant, who have hepatitis B, that they do much better when they're on long-term hepatitis B immunoglobulins with better survival and less risk of recurrence. And finally, in Australia, because there's a lot of patients on wait lists for liver transplants and there's very few available donor livers, there have been a recent use of from grafts from patients from livers basically who are core antibody positive but surface antigen negative, to increase the number of available livers to be transplanted. However, there's a high risk of essentially giving hepatitis B, transmitting hepatitis B to the recipient, and therefore the use of long-term prophylaxis is mandatory. However, what's important to note is that at the moment, there is zero recorded cases of any de novo infections in patients, as in patients who have acquired hepatitis B from a transplanted liver who are on prophylaxis. Therefore, it's very effective. That's really it that I wanted to talk about. Yes, that's the end of my talk. Thank you, everyone.
Thank you, Yumin.
Thank you, Dr. Yumin, for your very informative and very comprehensive talk. Now, this is the floor for discussions.
I think I see a question on the chat. Let's have a look. Is there any benefit about the use of antiviral medications in acute hepatitis due to hepatitis B virus? I think that's a really good question. As to whether there's a benefit, I'm happy for Mia to chime in, if she's aware of any benefits to it. In Australia, we generally don't, purely because there is a very good chance, especially in adults, that acute hepatitis B may be spontaneously resolved and cleared in a patient who has an intact immune system or immunocompetent, in which case they actually don't need long-term entecavir. Generally, once you start entecavir or tenofovir, it's essentially long-term. Mia, are you aware of any benefit, any role in acute hepatitis?
Yes, Yumin, thank you so much for your answer. I think, yeah, you're right. I mean, like we don't normally treat, acute hepatitis B or acute hepatitis B infection. However, if the patient have like some signs of acute liver failure, like, coagulopathy, if they are, encephalopathic, or it's severe, like hepatitis, in that case, bilirubin is really high. At one stage, like I had a patient whom we have to start them on tenofovir because, the ALT, AST, bilirubin just keep rising, like, pretty badly, jaundice. And I was also like quite deranged. So we have to talk to the transplant center and we started them on treatment. And if the patient is, like pretty unwell, then we might have to transfer them to the transplant center for close monitoring. But it was only, I have only seen like 2 cases so far with my, not very long career yet. But yeah, definitely not all the acute hepatitis B we don't treat. But if they have like, liver failure, like bilirubin is very high, coagulopathic, and if the patient is starting to develop encephalopathy, yes, you need to consider giving them treatment. Because, acute hepatitis B, the body can clear the infection on its own with time. Yeah. Thank you. I think there is another question you made.
Yeah. It looks like, is there any role of testing, I'm guessing Q for quantitative hepatitis B surface antigen? I guess my short answer would be not really in a day-to-day clinical setting. I know that certainly is quite useful in I think a research setting, and it is sometimes used in situations specifically where I guess you're considering maybe even withdrawing treatment or therapy. I personally, it's not something that I'm wondering either whether our local laboratory even tests. I think when I was in Victoria, another state of Australia, I think only certain particular hospitals that are liver centers do them. So on a day-to-day role, I would say no.
Yeah, I agree. So yeah, we test quantitative HBs antigen sometime if you want to, like consider to stop the, treatment after a few years, but we don't do it, routinely. And because, we normally check the hepatitis B DNA, which is the key to, to monitor the response to the therapy, because you want to suppress the viral load.
Thank you. So let me read some questions. Can PET interferon injection be curative treatment for Hep B? I had it can be curative treatment who are quantitative HBs antigen low. Is this true? That's a question.
Yeah, that's a great question. As to whether it relates to the quantitative surface antigen, I guess again, as Mian has mentioned, we do not routinely test for quantitative surface antigen, but certainly if you have a look, I think I'm still sharing my slides. I've come back to this slide, which I actually do not talk about PEG interferon just because it's not oftenly done, but yes, so if a patient is not wanting to be on lifelong treatment with entecavir or tenofovir, then yes, PEG interferon is a alternative for a definite 48-week treatment course, and yes, supposedly cure in the sense that they lose their surface antigen and no longer need ongoing treatment. Yeah, but unfortunately, I'm less certain about how the quantitative surface antigen factors into this, but I guess it makes logical sense. The percentage of prevention, oh, sorry, I'll let you carry on.
Yeah, so another question is percentage of preventions of hepatocellular carcinoma in cirrhosis or liver by giving antiviral treatment. And
HCC. I think the question is about, I think by giving antiviral treatment, like what is the percentage of prevention of HCC occurrence and also cirrhosis, I suppose. Yeah,
maybe.
Yeah, I don't think I have exact numbers, but certainly the alternate, I don't think it's 100% prevention, but certainly significantly reduces the risk. I think it's a strong argument, given the fact that it significantly reduces the risk, even if they're not cirrhotic. Say if they have, a family history, or if they have ongoing alcohol use, I would very strongly suggest putting them on tenofovir for that reason, because I guess the alternative is no treatment, in which case, they remain at a high risk. In terms of progression of cirrhosis, I think I do have it somewhere on my slide, but I might carry on answering some of these questions.
Yeah. So I think, thanks, Yumin. I think you're right. I mean, yeah, definitely, those antiviral therapy, they will reduce the prevalence of HCC, but bearing in mind that, the HCC prevalence is, the risk of HCC is increased with your viral load. So the higher viral load you have, then the risk or the chance of you getting HCC is higher. So you definitely, reduce the risk of HCC with those patients. I think, it depends on the patient by patient, but definitely it reduces the risk. For cirrhosis, I mean, cirrhosis as well is like hepatitis B is quite an independent risk factor for chronic liver disease in Asian population. And also, because of the chronicity that you've been exposed to hepatitis B virus, particularly in patients who got infection from, since birth. So the risk of cirrhosis of liver is quite high.
Yeah. Okay, so let me read another question. And is there any interpretations or calling which phase for the known case of HBs antigen positive patients for 20 years with negative HBe antigen and negative anti-HBe, or is that even possible?
That's a good question. I guess what we really care about is just the E antigen status, not less so about the E and the antibody. So I guess in your situation, they'd be, there would just be an E antigen chronic hepatitis or chronic infection. The main, I guess, the main factor is the E antigen status.
They just lost the E antigen with time, and they develop E antibody, but they still have HBs antigen.
Yeah. So let me read another question. Here's about vaccination. Before Hep B vaccinations booster dose, should we do investigation like HBs antigen? And when should we test for anti-HBs antibody level after taking vaccinations?
So I think to answer your first question, I think that's a really good question. If a patient's never had any screening for chronic hepatitis B, I think definitely I would do surface antigen. I would probably do core antibody as well to see whether they've had previous infection. Just, I guess, given the fact that in Myanmar, hepatitis B is so prevalent, I think any chance where you can screen them if they've never been screened, I would screen them, just because you might actually find that they, meet the indication for treatment, in which case, the booster doesn't really matter at that point. What they really need is tenofovir. When should we test for surface antibody level after taking vaccination? I guess that's a good point. On the basis of what I can think about from immunology, I think it's just a inactivated protein. I'd probably test it after 6 weeks, perhaps. I guess it is important to test it, which is a good point you bring up, and that there are some patients who need multiple boosters. Miat, unless you're aware of a specific time frame after a booster.
6 weeks is very fair. Yeah. 6 weeks, and then 6 to 8 weeks. Definitely. Next question, Yumin.
Next questions with scenario. And 56-year-old female with immune
Tolerance phase.
immune
Tolerance phase.
tolerance phase. But
But-
that is corrected questions. Immune control phase.
What does it mean?
I think she
Immune-
said immune tolerance phase.
Oh no, they've
if-
corrected. No, sorry, they
Con-
said yeah. This person said immune control.
control phase.
Yeah.
But ALT is about 30 every 6 monthly.
Mm.
Can patient treat with nucleotide analog or give other cause or find other cause or raise ALT? Thanks, sir.
Yeah, that's a really good question. That's a really good question. I think the other thing that, because this whole talk is about hepatitis B, that this patient, yes, the explanation for the ALT could be hepatitis B, but certainly I think it is worthwhile as it remains persistently elevated to also check, one, to make sure they don't have a co-infection, two, to check for other, maybe just other common causes of hepatitis like autoimmune hepatitis, whether there's ongoing alcohol intake, whether there's a possibility of the patient having some degree of non-alcoholic fatty liver disease that might explain this. And once you've excluded all of that, and the ALT remains, I guess by definition, what I've said in this talk, it is by that definition elevated. If you've excluded another contributory cause like autoimmune hepatitis or a co-infection, there's not really alcohol use. The patient is, has had an ultrasound that doesn't really show fibrosis, that doesn't show cirrhosis, sorry, and you've done a FibroScan and you've excluded all of that. I would consider treating this patient, because I guess the other problem is she's also above the age of 50. So she is now at risk of developing HCC. She needs to be undergoing surveillance. So for those reasons, I probably would, if the patient's open to taking tenofovir regularly, I probably would start her on treatment after that, after excluding other causes.
Yeah, I agree.
Yeah. And okay, thank you. Another question is, how long does it usually take to get seroconversions to HBs antigen and HB antigen with oral antiviral drugs? If no seroconversion occurs, does the patient need to take treatment lifelong?
Yeah, I think the main thing I guess you care about is the surface antigen. So once the patient has met the definition for starting treatment, whether if they're E antigen positive and their DNA is more than 20,000 and the ALT is elevated, once you've started, you just continue it essentially. So I guess what you're really referring to is what happens if the patient seroconverts their surface antigen, which is a good question. It doesn't happen very much. I think in one of my slides, the rate of it happening, I think, is less than 1% for entecavir and tenofovir. It's a good question. Once that does happen, and the one time I've seen it, I think what we did was we checked it a few times, because you do need to have seroconversion for a certain period of time. I might go back to the slide where I talk about stopping NAs. So you would be referring to the E antigen negative patients who have long-standing undetectable DNA. And I guess in this situation, there is surface antigen loss, then yes, the main thing in this situation would really be that they have undetectable DNA for 2 years. And yeah, in that situation, if they're not cirrhotic, if they don't need it because they're at high risk of hepatocellular carcinoma, then you perhaps can talk to the patient about it. But again, there is a risk of the hepatitis B flaring quite severely, with severe hepatitis once you stop. And also the patient does really need to be closely followed up with regular monitoring. I think, probably 3 monthly or at least 6 monthly, hepatitis B antigens, antibodies, DNA levels, liver function tests. And if you're a bit worried that perhaps the patient may not comply with all the follow-up and the monitoring, then certainly, given again how safe these medications are, perhaps you could also consider keeping them on it. But yes, to answer your question, you do describe a situation once you have seroconversion that perhaps you may not necessarily need treatment lifelong.
Yeah, but thank you, Yumin. That is, that's a very good question and answer. Yeah, I did have a patient who lost S antigen last year. I mean, he was on like treatment for more than 5 years, and finally we lost his HBs antigen. DNA was undetectable as well for more than like 3 years or so. And yeah, we did the, HBs quantitative in that patient, and it was all negative as well. So we stopped the treatment, but we closely monitor him every 3 to 6 monthly with an ultrasound and hepatitis B, full screen again. Yeah, that's a very fair point. But it's very rare, like you said, it's less than 1%. I only have seen one so far. Yeah, but in Burma, I would definitely keep them on, though. In Myanmar, I mean, because we have like, very high chance of getting reinfection. Yeah. I mean, I might, I would think it's case by case.
Yeah, certainly I think in Australia, it's still a reasonably new concept. Also, this stopping treatment tenofovir and tenofovir. There's only very recent data and some research on it, where you choose the best population to do it in. But in general, I think in our day-to-day practice, once they meet the need, the indication to start it, they remain on it lifelong. Yeah.
Yeah, very good.
Yeah. Okay. Thank you, Yumin.
Thank you so much, Yumin. Yeah, that was a very good talk. Excellent talk.
Yeah.
So,
by the way, can I add to 2 questions, Yumin?
Sure. Yeah.
Yeah, thank you. So if you mentioned that in treating Hep B infections with TNOF, so there's risk of low bone mineral density, right? So is there any regular interval did you test bone mineral density in patients treating with TNOF?
That's a good question. I think that would be worthwhile. As to the frequency of it, I can't really come up with a number on off the top of my head. I think if you do a baseline bone mineral density scan and it's abnormal and they're on tenofovir, I think the frequency of doing it would be quite regular. So I think, at least from our cirrhotic patients, who also are another cohort with a high risk of accelerated bone mineral density loss, I think we do them, I would imagine, every 2 or every 3 years. And that perhaps would be a frequency that you could consider. Certainly, if the baseline is normal, then you may not need to monitor so closely. But I hadn't looked into specifically that question for this talk.
Yeah, thank you, Yumin. So, and did you test bone mineral density before giving TNOF?
Yeah, I wouldn't delay giving the tenofovir, but I think once you've commenced it, I would do a probably baseline bone mineral density scan roughly around the time of starting the medication. And I guess if it looks like on the first one that the patient has osteoporosis, then certainly you would start treatment for osteoporosis. it's not. I think the reason there's not too much mentioned in Australia again is just because, and I personally am not too familiar. It's just that we almost all of our patients are on entecavir, and the only patients who are on tenofovir are pregnant women. So generally, we sort of are not too worried about it, just because if there's any concern, we just switch them to tenofovir because the cost is effectively the same. But to answer your question, I think I wouldn't delay it. I think, again, the risk of untreated hepatitis B probably outweighs, the potential risk of bone mineral density loss, and that is something that you can, also treat with vitamin D and calcium supplements and anti-resorptive therapy. And I guess does that allow you to change to tenofovir, change to entecavir in that case? Because you're worried about bone mineral density loss. I guess in your practice, would you think about just putting them on entecavir instead?
Yes, and in Myanmar, we use tenof more than entecavir. So actually, there's no practice to detect bone mineral density before giving tenof, and also during the treatment of Hep B infections, and we do not have practice to detect bone mineral density.
Okay.
Yeah.
I see.
Because in testing bone mineral density, but by the way, which scale do you use for bone mineral density measurements? FRAX score or not?
T-score and Z-score, we do.
Yeah, we don't calculate the FRAX score usually.
Yeah.
Thank you.
I think you should probably, like in Burma, maybe you could consider do like Joe.
Yeah.
If it is normal, you could consider doing it like every 2 years or so. Yeah, 2 to 3 years, like you mean said. I think that's reasonable, because if you found out they have osteopenia or osteoporosis, you're gonna put them on vitamin D, calcium, or anti-resorptive therapy, right? So you need to monitor them with another scan again in 2 to 3 years time. If they are not responding to that, then you might think of switching onto other medication. That's like you mean teach me yesterday only, so.
Okay.
Yeah. Is there another question, you mean?
Yeah. So before going to another questions, let me ask you another questions. Is it okay, you mean?
Absolutely, yeah. Okay, go ahead.
Yeah. Okay. So I became across my medical feeds, and I found my patients had chronic renal failure, and EGFR is less than 10 ml per minute, and also, unfortunately, it's HBV positive, and it is have indications to treat like chronic Hep B. So is there any suggestions to treat in that patient? And which drugs do you prefer to treat my patient?
Yeah, sorry, just to clarify. So the patient sounds like CKD 5,
CKD,
EGFR less than
10.
10.
Yeah.
Are they on dialysis? Are they on some form of renal replacement therapy?
No. On optimal medical therapy.
Okay.
No, not on dialysis.
Yeah, how old are they?
Sorry?
How old is the patient?
Yeah, 65.
65, okay. I guess my thought is this patient who's got advanced CKD, their prognosis, if they're not getting dialysis, is pretty high, right? The prognosis is pretty poor. They're likely to die in the next several years, I'd imagine. To answer your question, I guess what we've been taught based on our guidelines, based on the concern, especially with existing renal impairment and wanting to avoid any further renal impairment or toxicity, I would not give tenofovir. I think this will be a really good situation to give the renally adjusted dose of entecavir, the 1 tablet every 5 days, every 7 days, or TAF if that's available. that would be my thought. But at the same time, you can also make an argument to not treat because the patient is very likely to die from his advanced renal disease if he's not going for transplant or dialysis.
Yeah.
Yeah.
So it was a very hard decision to treat such kind of patients.
Yeah. Is he on treatment? Have you put him on something, or is it?
No.
What have you? No.
No,
Okay. Yeah.
because he did not agree to treat.
He didn't want to. Yeah. Yeah.
I wouldn't put on either. Hey, I agree.
Yeah.
His prognosis is very poor from this CKD pre-dialysis stage, and he's not gonna get dialysis. So yeah, and he's 65. Yeah. Definitely.
Okay, you mean maybe the last questions from the our audience. Is there any career limitations in Australia for healthcare workers with HBV positive to hepatitis?
That's a good question that I've personally not looked into, and I'm reading the Australian health guidelines now. Miad, are you familiar with this at all?
Actually, we just looked at it a few weeks ago. There is a very good one from Giza, you mean?
Yeah.
And also I think in Afra, you can practice if you have hepatitis B infection, but you can't pick like certain career which you need to do some invasive procedure like surgeons. You can do general medicine and other stuff, but not for surgery when you have like exposure with those invasive procedure. That's what my understanding is. You can still work as a nursing staff. You can still work as a doctor, general physician, I think GP. But if you're not going to do like some invasive procedure, that's fine.
Yeah. In addition to what you just mentioned, I'm looking at this guideline from health.government. These are Australian. So yeah, essentially what Mia was referring to, so for example, if you're going to be a cardiothoracic surgeon, then your risk of, exposure prone procedures is extremely high. So in which case, I think, you need to have essentially your gastroenterologist, your doctor, assess you to say whether, you're at risk, whether you are safe or whether you can perform these procedures. And if they say you can, then I guess, they can grant a health clearance. But I think there's a specific list of criteria listed in the guidelines. And there's also the other thing is, do you have to tell your workplace? And technically you're entitled to confidentiality. It's more about, I guess, morally, as a health practitioner, practicing with hepatitis B and potentially giving your patients or other co-workers Hep B. But yeah, not an easy question to answer, but generally you won't be discriminated per se. It's more just a public health thing. So in which case, if a gastroenterologist looking after you, have assessed you, looked at your compliance, looked at all your recent blood tests, undetectable viral loads, then they may say that, yeah, you can perform these high risk procedures under certain settings.
Thank you.
Yeah. Okay. Thank you. Thank you. It's been around 2 hours. And yeah, the 2 hour, 4 hour webinar. So maybe it's time to say thank you to the Yumins for your very informative and very patient and very clear questions on HBV infections and for your contributions in talk. And the last but not least, I would like to give my gratitude to Mami Mia Kai, who helped me a lot in having such kind of great webinars. And I would like to thank to my junior and senior colleagues who joined with us in these webinars and also questions and also for the questions. So thank you.
Thank you so much, Yumin. It was really good. Thank you.
Thank you.
Dr. Minso as well.
Yeah, no, Thank you both. Yeah, thank you for this opportunity. I again learned a lot from going over my slides, and thank you to everyone who've stayed till the end of the talk and participated in the questions.
Yeah.
Thank you very much.
Yeah, thank you. And so I'm going to end the sections.
Sure. Thank you, Yumin.
Great. Thank you.
Thank you.